Welcome, everyone. Welcome to the MSG ERC Grand Rounds webinar series. My name is Luis Ostrowski. Next slide, please. And I'm happy to welcome you to this webinar. This is our first webinar for the year. And we're going to be addressing the WHO fungal priority list. It is a pleasure to co-host this webinar with my good friend, Peter Papas, and I'm going to show you the program in the next slide, please. So we're going to be discussing the WHO fungal priority list. That's going to be presented by Ana Alastre Izquierdo. Then we're going to talk about the 4 top pathogen categories in this fungal priority list. We're going to be discussing cryptococcosis, candidiasis, then we're going to have a break. Then we're going to go to the endemics and molds, and we are going to be saving all the questions for a panel discussion towards the end of the webinar. Next slide, please. It is a pleasure to present our faculty for today. As I mentioned, this webinar is co-hosted by Peter Papas, who is a professor of medicine and the Division of Infectious Diseases at the University of Alabama School of Medicine. We're also joined by Ana Alastre Izquierdo, who is a scientist at the Mycology Reference Lab at the National Center of Microbiology in the Instituto Salud Carlos III in Madrid, Spain. Also joining us from the UK is Professor Joseph Jarvis, who's a professor of Tropical Medicine and International Health and the London School of Hygiene and Tropical Medicine, who's carried out some of the most important research in cryptococcosis in Africa. Also joining us from Georgia is Dr. Jose Vasquez, who's the chief of the Division of the Infectious Diseases and a professor of medicine at the Medical College of Georgia and Augusta University. From California, Dr. George R. Thompson III, who's a professor of medicine at the Department of Internal Medicine and Division of Infectious Diseases at UC Davis, International Authority on Coccidioidomycosis. And last but not least, all the way from Australia, we have Dr. Sharon Chen, who's the director of the Center for Infectious Diseases and Microbiology at the New South Wales Health Pathology Westmead Hospital in Sydney, Australia. As you can see, we have an outstanding faculty today. It's going to be a treat for everybody to hear these researchers and key opinion leaders discuss the trends in medical mycology. Next slide, please. A few acknowledgements and housekeeping notes. This is an educational initiative that was funded in part by a cooperative agreement with the Centers for Disease Control and Prevention and the University of Alabama, Birmingham. And again, this is organized by the Mycosis Study Group and supported by our educational partners, Terranova Medica. You can ask questions at any time during the talks by entering them in the QA function of the chat. We will be collecting all those questions and asking the questions of the faculty during the roundtable towards the end of our session. And finally, I'm happy to report that an archived version of this webinar will be available at our website, where we deposit all our webinars, which you can see there. And without further ado, I'm going to turn it over to Ana Alastre Izquierdo, who's going to walk us through the process of creating this WHO fungal priority list. Ana, welcome.
Hello, everybody. Thanks very much, Luis, for the nice introduction, and thank you for organizing this interesting webinar. I'm very excited because I think it's the first time I'm gonna present in this work with the final result in it. So we've been expecting it for a long time, and finally the report was released in October last year, but and until now we've been only able to discuss the methodology, but today we can release the whole list, and I'm very happy that I'm here. So thank you very much. Please, can you go to the next? Just to say that this presentation has been prepared together with Hatim Sati, that is the person that has been doing all the work from WHO in the fungal priority pathogen list. He's been in charge of all this work. So presentation has been prepared from both of us. So next slide, please. I think you all, as been here, know most of these things, but I would give you a little bit of background and why was this fungal list created. So you know that there is a high mortality related with fungal infections, and also the morbidity is very high. We are facing in the last years an expand of susceptible population. We've been knowing for many years neutropenic patients are a good, really in a host for fungal infections, but we've been discovering different hosts as COVID patients, flu, and other hosts that are in critical for fungal infections. So the population is expanding. There are only 4 classes of systemic antifungal drugs available. We can argue there are 3 or 4, depending if you consider fluorocytosine 1, but mainly 3 plus 1 classes. They are mostly associated with side effects or other problems. And one very important point that I will guide you through, which is from my point of view is a chicken and egg problem, is the global access to quality antifungals, and affordable and effective diagnostics is completely unevenly distributed, and especially low and middle income countries in which, as we know, fungal infections are more frequent. So this, as I was saying, is a kind of chicken and egg, because this the diagnostics are not very useful in many of these pathogens, and whenever there is a good diagnostic in place, it's not available in many places. So this lack of diagnosis brings us to that we don't know the burden of disease. It's we can estimate them, but it's very difficult to have a real number of burden of disease. This means that if you don't know the burden of disease, the resources are very limited, because the first thing everybody asks you is, what's the burden of disease? And if you don't have that, then you don't get resources. That means that you don't have access to antifungals, and you don't have money to develop new diagnostics. So this is a very complicated circle from which it's difficult to exit. And this is one of the problems that we have realized doing this exercise. Next slide, please. In addition to this, we know in the last years antifungal resistance is emerging and exacerbating the burden of invasive fungal disease. We all know about Candida auris or azole-resistant Aspergillus fumigatus are real problems in some countries, but there's also Candida parapsilosis azole-resistant strains which are emerging. So antifungal resistance is a real problem now. It's fungal infections is a poorly understood and under researched field, and some studies have found that less than 1.5% of all infectious disease research fundings go to mycology. So we really have a lack of funding here. Linked to this is a lack of awareness and knowledge. So we have not enough people devoted to fungal disease, and then there is lack of awareness also in the clinical curriculums in many places. And in the last year, it has been an emerging evidence that climate change has an impact on the geographic distribution of some fungal pathogens. So some people is hypothesizing that some regions that have been endemic for some pathogens could probably be broadened in the next years. Next slide, please. So for all of this, WHO decided to make all the work to develop the first fungal priority pathogen list with the 4 main objectives that are here. One is to direct and drive efforts, research and development efforts toward the pathogens that were prioritized, and mainly, as we will see later, the ones that pose the largest public health threat. And then define the priorities to align investment and funding, enable international coordination in research and development to innovate new and optimize therapeutics and diagnostics. And also, one of the aims of this list would be also from WHO to facilitate a regular review of the antifungal development pipeline that is going undertaken now, and to track trends and identify which gaps are there. Next slide. So this is a very complicated slide probably, and I will try to guide you through how has been the methodology. This has been a tremendous effort for so many people, and I think I have more acknowledgement slides that I have been in my whole life. You will see later, but there have been, but for sure, many of you would have contributed to this. I'm very thankful, and we are all very thankful for this. And this process has been more than 2 years. I reviewed the other day when was the first meeting, and we had it in March 2020, so just on the COVID side. But we started very early. So we first formed the advisory group from WHO. They identify experts around the world and identify the advisory group. Then we defined the protocol, the study protocol, and WHO pre-selected some pathogens, possible pathogens based on the literature review. And then these were expanded with the advice of the expert group, as we'll see later. Then some selection, we defined some criteria to which all these pathogens will be classified. And all these criteria had different levels to assign, as we will see later. Then a series of systematic reviews were performed very nicely from the Sydney group that were commissioned to do all this work, all the systematic reviews. And during this time, at the same time, so all this methodology, some of the steps were done, were overlapping, as we'll say. And then we were performing registration of globally representative mycology experts that then participated in a survey, the DCA Discrete Choice Experiment Survey, to determine which are the weights of each of these criteria. I hope I can explain a little bit later. Then each pathogen was defined with a profile according to these 10 defined criteria, and all the levels that were assigned according to the systematic reviews. And next step was a best-worst survey, focusing on only senior experts around the world, in which they define according to public health importance also the predefined pathogens. And then a final ranking and evaluation of the results, including a sensitivity analysis, was performed with all the people that participated in the technical advisory group and the commission group from Sydney and all the group from WHO. So next, please. So these are, I will try to explain you a little bit each of these steps. The first one, as we said, the WHO detected some of the most important pathogens and selected according to systematic reviews, and the expert group added several others. So the group of pathogens to be prioritized is in the left side of the slide, and all these were defined. And then in the third step was, as I say, define the criteria among to which these pathogens will be categorized, and in each criteria, deaths, inpatient care, complications and sequelae, antifungal resistance, they have different levels. So each criteria, each pathogen was assigned a level in each of these 10 criteria. As you can see, the criteria, of course, for many of the pathogens that we wanted to prioritize, there was not enough data in the systematic review, so we had to add expert opinion, and hopefully this will mean that there has been a gap, and in the next years we will try to fill these gaps so we have better information in the coming revision. So next slide, please. So these are the systematic reviews that were performed thanks to the group at the Australia-New Zealand study group in the Sydney University, in which they, as you can see here, they review a lot of information in all these pathogens, and each of these full systematic reviews to describe these pathogens according to the criteria. Next slide, please. So this is an example of Candida auris systematic review. It's in each of them there is a summary and a conclusion, and you can see here each of the 10 criteria on the left side. We subtracted from the systematic reviews all this information, and according to this, next slide, please. Oh, sorry, and I will come back to that later. So and then at the same time, we will do a DCA survey to determine which of to give a weight to each of the criteria to, after all, sum up and do the final. Next slide, please. So in this, 400 people participated. This is the survey, an example of how this survey of these 400 mycologists that participated was looked, and it's like they were given several examples of this situation, also a pathogen A and pathogen B related to these 10 criteria, and you have to decide which one would be more important from your point of view, taking into account this hypothetical pathogen. So never, it was never a defined pathogen or a real example, but it was only hypothetical pathogens defined according to this criteria. This was repeated several times across the exercise, and 400 people responded to this. Next, please. Then we did another survey in which like 50 senior experts define, in this case, which are, according to their experience, the most important, the pathogens that have more public health importance. And this was the best worst survey and exercise. Next slide, please. This survey, as you can see here, you have to grade which are the, every time this was the same exercise for pathogens several times were, and in this case, these pathogens were specifically named under their scientific names, and you have to define which of these 4 pathogens has the highest public health importance and which one has the lowest public health importance. This was repeated several times within the exercise, and 50 people responded to this survey. Next, please. So, and this was the exercise. So the first, as we said, the first was that we defined according to the 10 criteria, each of these pathogens was defined to one of the categories within the criteria. These criteria were weighted through the survey of the DCA survey. So it's, for example, antifungal resistance was clearly one that had a lot of impact, but also mortality had a lot of impact in that survey. So out of that, we have the first column, you see base research and development rank, in which you can see, for example, the first one in this case was Lomentospora prolificans. Then the second column, the one in the center, you can see public health rank. In this, the pathogens were classified according to this was most important, but less important according to public health. And the classification was completely different from the research and development, but we wanted to have this list that jointly with both information. So we had to clearly identify which are the research and development gaps, but also taking into account the public health important, because this is a WHO exercise. So then at the end, we combined these 2 rankings, and then this was the final list that you can go to the next slide, please. And this was the final grouping. So first, there is a critical group in which we have Cryptococcus neoformans, Candida auris, Aspergillus fumigatus, and Candida albicans. These were defined as the very critical because of several reasons, but I think we would all agree that these are the most important pathogens according to burden of disease or resistant patterns. Then we had the high group in which most Candida glabrata or Candida tropicalis parapsilosis were included, but also some molds as Fusarium or Mucorales that have some problems in antifungal treatment. Also Eumycetoma agents in this case were also grouped, and one of the endemic patients or primary pathogens is Histoplasma. And then the third group that was classified as a medium, where most of the other pathogens were included: Ceosporium, Lomentospora prolificans, Coccidioides, Candida krusei, Cryptococcus gatti, Telenomyces marneferi, Pneumocystis jirovecii, and Paracoccidioides. Of course, this list, one of the things that we have highlighted during the whole exercise and also in the report, has to be adjusted because there are some places in which some pathogens are more important than others, but this exercise was a global exercise and we had to identify which are the pathogens according to the whole exercise. So next, please. Also, apart from defining this list of priority pathogens, we define three main areas of actions that would need to be addressed during the next year. And I will guide you through this. Next slide, please. So one of the priorities was in surveillance, and we identified several gaps. Mainly, we have to enhance diagnostics capacity, and the labs, there are many places in which there are no enough lab capacity to diagnose fungal infections. So this has to be detected and enhanced in the coming years, but not only with diagnostic PCR techniques, but also imaging and so on. Also, when the resources are very limited, we understand that at least we have to establish one central mycology laboratory. Then we have to integrate the WHO model list of essential diagnostics that most of the diagnostics of these pathogens are included. Also develop disease registry and surveillance networks at national and international levels, and utilize surveillance data to understand the burden of invasive fungal diseases and drug-resistant and informed public health intervention. Next slide. The second area was research and development. We need to focus in develop new and innovative antifungals, improve the existing therapies, support research to develop new rapid diagnostic tests for the priority pathogens that are suitable for low and middle income countries, research to improve efficacy, efficiency, and quality of fungal identification and antifungal susceptibility testing that is lacking in many places, and then also enhance public-private partnership and multi-country collaborative research platforms. And the next, please. And then the third area was for public health. We need to incorporate the fungal diseases and fungal priority pathogen list in medical and clinical training programs, improve also the coordination and efforts to align action on invasive fungal infections and antifungal resistant prevention and control, promote existing infection prevention and control measures, and develop new prevention measures at both healthcare facilities and the community level. They promote the rational use of antifungal agents, development of evidence-based treatment guidelines that we know are lacking in some of these pathogens, and develop mechanisms and policies to ensure equitable, affordable access to quality antifungal agents using the WHO model list of essential medicine. And next, please, I think I'm just finishing with this acknowledgement that from my point of view, are the more important slides. Many people has made a lot of effort to contribute to this. I would especially like to thank the people at WHO that lead all the work. As I say, Hatim Sati was the project leader, and all the team there, Peter Beyer, Valeria Gigante, Pilar García Bello, but also Haile Getahun, the director, and Hanan Blanqui, the ADG for IMR division. Then all my colleagues at the expert group that contributed enormously, and the contractor in the Sydney University. And then please go to the next slide quite quickly, just to let you know that there are so many people, and next as well, that contributed. Next slide, please. External observers, next. And the colleagues from WHO headquarters, but also from IMR division and also regional offices, the AMR stack. Next slide, please. And all these people from the commission group from Australia, New Zealand, mycosis interest group, and I want to highlight here Justin Beatsley, Orla Morrissey, and Jan William that contributed enormously to this work. And next slide, I think, is my last one, also to the global senior mycology experts and the expert that contributed to the surveys, and especially to the mycology societies that distributed all these surveys, and the financial support that is also important. And with that, I would like to thank you for your attention, and yeah, we're happy to take questions at the end of the seminar. Thanks very much, Luis.
It is my pleasure now to turn it over to Professor Joe Jarvis, who's going to address the challenges and priorities in cryptococcal meningitis. Dr. Jarvis?
Great. Well, thank you very much, and thank you for the opportunity to present today. Next slide, please. So this work that I'm presenting is, of course, the basis of a huge amount of work by a very, very large number of people spread out across the world, in particular, many, many collaborators in Africa, where we've been performing our trials for many years. Too many to thank individually, but they're listed here. Next slide. So I'm going to focus on HIV-associated cryptococcal meningitis for the next 15 minutes or so, for reasons that will become clear, hopefully, throughout the talk. I'll give a very brief background to the epidemiology and then discuss treatment, looking at current treatment outcomes, findings from recent trials with a particular focus on new short-course therapies for cryptococcal meningitis. I'll discuss potential adjunctive therapies, some novel drugs that may be of interest in the near or perhaps not so near future, briefly touch on diagnostics and screening and what the challenges and opportunities are here. Next slide, please. So this audience probably doesn't need much introduction to Cryptococcus. So it's an encapsulated yeast. It's ubiquitous. We're probably all exposed by the time we reach adulthood. But in the context of a functioning immune system, this fungus, which is inhaled, would either be cleared immediately, phagocytosed by alveolar macrophages, or walled off within a granuloma. But in the context of defects in T-cell mediated immunity, this infection can reactivate from a pulmonary focus, it can disseminate, and it has a particular predilection for the central nervous system where it causes a really devastating meningoencephalitis. So it's primarily a disease of immunocompromised hosts. And worldwide, HIV is by far and away the most important risk factor for this infection. Next slide, please. So, although there's been huge progress in the public health response to the HIV pandemic over the past 2 decades, we still face significant challenges. And UNAIDS estimate that there were 650,000 deaths due to AIDS in 2021. That's one life lost every minute of the year. And we're way off our targets of ending AIDS deaths by 2030. And if we look at what actually kills people, nearly all of these deaths are in people with advanced HIV disease, i.e. CD4 counts below 100, and they're primarily caused by just three infections: cryptococcal meningitis, tuberculosis, and bacterial infections. And cryptococcal meningitis alone accounts for almost 20% of all AIDS deaths globally, so an estimated 180,000 cases per year. So a major cause of mortality and morbidity. And if we're going to reduce AIDS deaths by 2030, it's absolutely essential that we tackle cryptococcal meningitis. Next slide, please. So, as you may expect, the bulk of the disease burden very much matches where we see the bulk of the HIV disease burden in Africa. But we do see this disease in our settings in Europe and the States. There are an estimated 3,000 cases of HIV-associated cryptococcal meningitis annually in the States, about 4,400 in Europe. And even in high-income settings, case fatality rates are high at around 10 to 15%. And additionally, we see several thousand cases of cryptococcal meningitis in individuals who don't have HIV infection, but other causes of immune suppression, including transplant recipients and those with other defects in their cell-mediated immunity. Next slide, please. So when we first started doing cryptococcal meningitis trials in Southern Africa in the early to mid-2000s, the mainstay of treatment was fluconazole monotherapy. And outcomes with fluconazole monotherapy for cryptococcal meningitis are terrible. 10-week mortality rates of 96% reported from Zambia, slightly lower rates from Uganda. And in a series of dose escalation studies where we increased the fluconazole dose from 200 to 400 milligrams daily to 800, 1200, even higher, we did see slightly lower mortality, but still well over 55% in clinical trial settings, probably more like 70% outside of clinical trial settings. So clearly inadequate treatment with this fungostatic drug. And unfortunately, this remains a very common form of therapy across much of Africa today because of its ease of oral administration and the fact that it's either freely available through donation programs or very cheap. But clearly we need to do better than fluconazole. Next slide, please. So what was used in high-income settings in the late 1990s when we were seeing lots of HIV-associated cryptococcal meningitis was amphotericin B deoxycholate. This is a much more fungicidal drug. Outcomes are certainly better than with fluconazole, yet still not that great. Next slide, please. And a big problem with standard amphotericin B deoxycholate is that it's a very toxic drug, difficult to administer, and particularly when we're trying to give a 2-week course of intravenous therapy in very resource-limited settings where we may not be able to monitor renal function, we may not be able to monitor electrolytes, we have problems with drip site infections, we can't manage anemia very well, and we're trying to give a drug that causes thrombophlebitis, nosocomial sepsis in 15% of individuals, infusion reactions, quite marked anemia, a mean drop of 2.3 grams per deciliter of hemoglobin over 2 weeks, which when you're starting with a hemoglobin of 8 or 9 in an unwell HIV positive patient population is very consequential potassium and magnesium wasting. So new therapies were needed that could be safely administered in Africa, where the bulk of the disease burden was. Next slide, please. One approach would be to give shorter courses of amphotericin B-deoxycholate. So there were some animal model data. These are data from a rabbit model looking at fungal burdens in the brains or CSF and brains of rabbits. And you can see that with an abbreviated 3-day course of amphotericin B-deoxycholate treatment in rabbits, you achieve almost the same clearance of fungus from the CSF as you do with a standard long duration of therapy. And could you just click the animation for me? If you look at the brain burdens in these rabbits at the end of 14 days of treatment, you see that they were almost the same with just 3 doses compared to 14 doses. So next slide, please. This idea of abbreviated courses of amphotericin B-deoxycholate has now been tested in humans. So this is the ACTA trial led by Sheila Malloy and Tom Harrison and colleagues. And the primary question here was whether we could shorten the duration of amphotericin B-deoxycholate treatment in cryptococcal meningitis from 2 weeks to 1 week. But it was quite a complex trial because as well as that differing duration of amphotericin B-deoxycholate, they looked at a different second agent, either fluconazole or flucytosine, and they also had an oral arm of fluconazole plus flucytosine. And the bottom line is shown there, and you can see that the best performing regimen in this trial was 1 week of amphotericin B-deoxycholate plus flucytosine, which perhaps slightly counterintuitively had a markedly lower mortality than 2 weeks of the same regimen. And that's probably because you were getting as good a clearance of fungus with that abbreviated 1 week course with flucytosine as you did with 2 weeks, but you were avoiding much of that toxicity. And it looked like that toxicity may actually be killing patients. However, it's very important to note that if you look just to the left of that first red box, if we give an abbreviated course of amphotericin B-deoxycholate with fluconazole, the outcomes were really poor. So clearly you need that second fungicidal agent in the form of flucytosine if you're giving abbreviated treatment courses. Next slide, please. But of course, we would almost never use amphotericin B-deoxycholate in a hospital in the UK or the States. We'd use liposomal amphotericin. So we know that this formulation of amphotericin is much less nephrotoxic, that we can give much higher doses safely. We know that it's got excellent tissue penetration and a long tissue half-life, which means we should be able to deliver highly effective therapy with very few doses. And we know from another infection, visceral leishmaniasis, that giving a single high bolus dose does seem to work. So in visceral leishmaniasis, giving a single 10 milligram per kilogram dose was just as effective as conventional 14-day dosing of standard doses. But in cryptococcal meningitis, its use had previously been limited by cost. But if we could give a very short course of liposomal amphotericin B, if we could negotiate reduced pricing on that basis and reduce the duration of hospitalization and the need for toxicity monitoring, this might actually be a practical and cost-effective option. So there was a need to define the best way to use this drug in the African context. Next slide, please. Like with amphotericin B-deoxycholate, there were animal model data suggesting that abbreviated courses of liposomal amphotericin should be good. This is now a mouse model looking at what happens if you give a single very high dose of liposomal amphotericin in a mouse. And in the red line, you see the plasma levels, and the black line, the brain levels. And after a single dose, you can see that there's a very rapid increase in that brain level, and then it persists with a very long terminal half-life, supporting the notion that we could give these abbreviated therapy. The next slide, please. So on the basis of this, we designed the AMBITION study, and initially we performed a phase 2 clinical trial with an endpoint of early fungicidal activity or rate of clearance of infection from the CSF. We had a control arm of standard dose liposomal amphotericin given at 3 milligram per kilogram per day for 14 days with fluconazole. And then we looked at a single high dose, 10 milligram per kilogram on day 1, a single high dose on day 1 and a second high dose on day 3, or a single high dose on day 1 with subsequent doses on day 3 and day 7. Next slide, please. This was a non-inferiority trial. What we wanted to do was show that just giving a single high dose was not inferior to 14 days of dosing, because the cost and practical implications of this would mean it would be a preferable way of dosing the drug. And what we see is shown there. The dots show the point estimate in the difference in clearance between single dose and control at the bottom, 2 doses and control in the middle, 3 doses and control at the top. And you can see 3 things here. So first of all of our short course high dose treatment regimens were non-inferior to the control regimen at our predefined non-inferiority margin. Secondly, the point estimates actually are in favor in all cases of the short course high dose arm, suggesting that you may actually get faster clearance by giving a very high bolus dose in the context of fluconazole as a second agent. And thirdly, there was no clear dose response. So adding in a second or a third high dose didn't seem to improve the rate of clearance. It looked like you got almost maximal fungicidal activity from that single high dose. Next slide, please. So that formed the basis to our phase 3 ambition trial. We knew from the ACTA trial that you could get away with abbreviated courses of amphotericin B deoxycholate. We knew from that trial that flucytosine was an essential component of those regimens. And we knew from our phase 2 study that giving a single 10 milligram per kilogram bolus dose looked like possibly the best way of giving liposomal amphotericin B. Next slide, please. So we designed a trial with an experimental regimen of a single 10 milligram per kilogram dose of liposomal amphotericin B given with flucytosine and fluconazole based on the ACTA trial results showing that that was a very good oral backbone. And we compared it to what was then the World Health Organization standard of care, which was the 1-week amphotericin B deoxycholate regimen given with flucytosine from the ACTA trial. Our primary outcome in this trial was all-cause mortality. Next slide, please. We recruited 844 participants over a 4-year period across several countries in East, Central, and Southern Africa. Next slide, please. And the headline results were published in the New England Journal in March of this year, and they're shown here. So with our experimental single-dose liposomal amphotericin B arm, we had a 24.8% mortality compared to 28.7% mortality in the control arm of the then World Health Organization standard amphotericin B deoxycholate regimen. This easily met our non-inferiority criteria in unadjusted analysis. And in an adjusted analysis, we almost met superiority criteria, suggesting that the single high dose may in fact be superior to the WHO standard of care. And as well as being easier to give and leading to lower mortality rates, the liposomal amphotericin B-based treatment was, as expected, much better tolerated with significantly fewer grade 3 or 4 adverse events, as you can see in the bottom right panel there. Next slide, please. And just to highlight that a bit, this really was significant, this toxicity benefit. So this is looking at anemia, which is one of the main problems we see with amphotericin B treatment in cryptococcal meningitis. And you can see that in the ambisome arm, 13% of individuals had a grade 3 or 4 anemia during the course of treatment, compared to over 40% with the control arm. So really a marked difference in toxicity profile there. Next slide, please. This trial, when we first presented it at the AIDS conference in 2021, really had quite a large impact. And could you just click through the animations for me? It was picked up by several news sites. Médecins Sans Frontières put out a press release highlighting the importance of this trial and making the point that for this to actually work, we had to have access to the drugs and the commodities. And Gilead, who make liposomal amphotericin, in response to that, put out a statement committing for not-for-profit pricing for liposomal amphotericin for this indication, really opening up the possibility that this treatment could then be used in a widespread way across the African continent and other low and middle income countries. Next slide, please. The pathway to impact of this trial was really very rapid. So after the publication of our full results in March of last year now, not this year, just 3 weeks later, the World Health Organization put out rapid advice, updating their guidelines, making this the first-line recommended therapy for cryptococcal meningitis globally. And I think even more importantly than that guideline change is the fact that we know that this regimen is now already being used in routine care across many countries in East and Southern Africa, with many thousands of patients already treated with the new treatment regimen. So it really has been a fairly rapid translation from that clinical science and the clinical trial into guidelines and into practice. Next slide, please. It's also stimulated some interest again in the activist and advocacy community, and this was at the AIDS conference in Montreal last year, where there was a stage invasion with people waving placards demanding access to treatment for cryptococcal meningitis in communities affected. Next slide, please. Sorry, my time is running out, so I'll try and rush through. Now, is this applicable to high-income settings? Most high-income guidelines recommend 14 days of standard dose amphotericin, liposomal amphotericin with flucytosine. Can you just click on the animation for me? Which is actually not based on a single clinical trial. That regimen has never been tested in a clinical trial. And it's possible that patients in high-income settings maybe are at risk of being left behind with unnecessarily long courses of daily liposomal amphotericin B. Next slide, please. So we recently published an opinion piece in Clinical Infectious Diseases arguing that in terms of antifungal efficacy, in terms of side effects, in terms of acceptability, and in terms of cost, we think that the argument or arguments favor using this regimen in high-income settings as well as low-income settings, but perhaps we can touch on that in the discussion a bit. Next slide, please. So very quickly in the remaining, you can click through that slide, in the remaining 2 minutes, can we lower mortality with adjunct therapy? So as you will have noted, we're still looking at almost 25% mortality. Can we do anything else? Well, what about giving earlier antiretroviral therapy to try and boost people's immune system, help clear the infection? Would that work? Well, we know for certain that doesn't from the COAT trial, clearly showing that if you start early ART in the context of cryptococcal meningitis, you actually increase mortality, meaning that we delay ART now for between 4 and 6 weeks after diagnosis. Next slide. We tried adjunctive sertraline based on some in vitro data. That didn't work either, so not recommended. Next slide, please. Adjunctive dexamethasone in tuberculous meningitis and bacterial meningitis. We may give steroids to try and dampen down inflammatory responses. Could the same thing be done in cryptococcal meningitis? Again, a conclusive no, it can't. Dexamethasone appears to worsen outcomes. It increased adverse events, it slowed fungal clearance, and it actually led to higher mortality rates. So not a good idea in the context of acute cryptococcal meningitis. Next slide, please. What about boosting the immune system? So actually in cryptococcal meningitis, it's a lack of inflammation in the context of very advanced HIV disease that seems to cause the problems a lot of the time. Perhaps instead of giving steroids to dampen immunity, we could boost it. And we have looked at this briefly with adjunctive interferon gamma. Interferon gamma clearly plays an important role in host defense. If you have higher levels of gamma at baseline, you're more likely to survive. Next slide, please. And in a phase 2 trial that we performed, and Pete Pappas and colleagues performed another phase 2 trial of this a few years earlier, it does look like giving adjunctive gamma actually increases the rate of clearance of infection, but this is yet to be tested in a large phase 3 trial. Next slide, please. What about new drugs? Well, there are several things on the horizon. There are some novel azole-type drugs, the Viamet compounds, the Amplix, now Pfizer compounds have some anti-cryptococcal activity, and there are oral formulations of amphotericin B, which are currently being tested. Next slide, please. I've said starting phase 2 trials. In fact, the oral amphotericin is in a phase 3 trial as we speak. If you'd asked me a few months ago about whether I thought any of those were really going to revolutionize cryptococcal meningitis treatment, I think my answer would probably have been no. But John Perfect and colleagues published these data recently from another one of the Amplix drug formulations, which is in the Pfizer stable of drugs. And this is looking at rate of clearance of infection in an animal model. And what you can see is that blue line there is getting you an incredibly fast rate of clearance of infection, even compared to amphotericin B in the gold line. So we've never really seen a drug like this before. And I think that this drug, if it is ever converted into clinical practice, may actually be something very interesting to look at in cryptococcal meningitis. But watch this space. Next slide, please. Sorry, so I'm running over slightly. So very quickly, could we intervene earlier prior to development of severe disease? We know that Cryptococcus goes from exposure into a latent phase, CD4 count drops. Presumably, there's an asymptomatic period of infection while it reactivates before it disseminates and causes a meningitis. And if you put in the animation there, what we could maybe do is intervene there. And we could screen people for cryptococcal antigen, detect them when they're positive before it's disseminated to the central nervous system, and give preemptive treatment to prevent infection. Next slide, please. This has been markedly facilitated. We've got data showing that indeed that is the natural history of disease and suggesting that should be possible. Next slide, please. And a very good lateral flow test, which can easily be done at the point of care with fantastic sensitivity and specificity. Next slide, please. So on this basis, the World Health Organization has recommended cryptococcal antigen screening of all individuals with CD4 counts below 100 and a conditional recommendation for individuals with CD4 counts below 200 to try and detect this subclinical infection and enable early intervention. Next slide, please. There are still some challenges there in that with fluconazole therapy, which is what we're currently giving to antigen-positive patients, we know that the mortality does still remain quite high, so we may have to give more intensive treatment. Next slide, please. And that may be facilitated through quantifying antigen burden using semi-quantitative antigen tests. Next slide, please. So just as a final note, there are several trials ongoing looking at new treatments for people with early subclinical cryptococcal infection, including enhanced oral therapy with fluconazole and flucytosine, or giving single high doses of liposomal amphotericin. Next slide, please. So I'll stop there. Sorry for running over by a minute or two, and happy to discuss any of this in the questions at the end.
Up next is Dr. Jose Vasquez from Medical College of Georgia, who's going to talk about Candida infections. Joe,
Okay,
take it away.
thanks, Luis. Yep, thank you. And welcome to everyone. Next slide. So I thought we'd go through just to make sure the disclosures, as you can see here, I do have stocks in Lowe's and Home Depot, just in case that's a conflict of interest. Next slide. A couple of objectives. Number one is to describe the increase in significance of Candida infections, as you can see from the WHO priority list, details some changes in the epidemiology of Candida, risk factors associated with Candida infections, diagnostic methodologies, which have not fared well over the past 20 years, update in the management of Candida, and then define some unmet needs and possibilities in candidal infections. Next slide. So as everybody's aware, fungal infections are a significant threat to public health, as witnessed now finally by the CDC putting out recommendations in the WHO, increasing in frequency, as we've heard throughout today, the lack of adequate, rapid, and sensitive diagnostic modalities. And this doesn't pertain to the academic centers, that actually pertains to basically everybody else in the rest of the world. The increasing resistance to all antifungals, not only the azoles, but also the echinocandins. This increase that we've seen in Candida, Aspergillus, and Mucor during the COVID pandemic, as I think just the beginning, and then the increase in cost and length of stay that the candidal infection, the fungal infection produce. Following slide. Next slide. So Candida species, as everybody is well aware, represents one of the major components of morbidity mortality. In prior studies, it was the fourth most frequently isolated organism in blood culture isolates. It is currently the second leading pathogen among bloodstream infections in acute care hospitals. Amazingly enough, after studying this for many years, mortality rates still remain high in the area, averaging about 30 to 40%, depending on the underlying disease and host. And one of my pet peeves is the fact that the incidence is still underrepresented and diagnosed antemortem. So frequently this diagnosis is actually made post-mortem. And I was going to show you that with a study that was published a few years ago. Following slide. So this is the WHO fungal priority. You've seen this already, but I just want to elaborate that albicans and ors are in the critical priority. High priority, we have Candida glabrata, tropicalis, and parapsilosis, and the medium priority, we have Candida krusei. So we have many different organisms, but you can see that 6 of them are within the Candida genus. Next slide. A study that was published several years ago, actually, in 2007, looked at 1,872 isolates from about 1,700 patients, and I have this up here just to point out that of all the pathogens that were recovered in fungal infections that were diagnosed, 71% are due to the Candida species. So if you are to learn, certainly a fungal infection, making sure that Candida is one of the top ones. This is followed by Aspergillus at about 15%, and Zygomycetes or Mucor at about 1.5 to 2%. The other thing that you can see there is the increases that we've seen with the non-albicans Candida species compared to Candida albicans, which in many institutions has actually flipped. Following slide. Next slide. So this is a study that was published 2 years ago. It was from the CDC, the Emerging Infections Program through the CDC, is an active population-based surveillance from 2008 to 2017, about 17 million people, showing you not only the incidence of candidemia, this is candidemia without invasive candidiasis of 7 per 100,000, but also the all-cause mortality in this group, which was the highest of all at 25%. Compare that to the C. difficile mortality of 1.3 to 9.3%, invasive MRSA infections at 13%, and pneumococcal pneumonia at 11.4%. So certainly a significant disease with significant all-cause mortality. Following slide. One of the things that we do know that every month or two, we have a new species of Candida. There are over 150 species of Candida. These are just some of the leaders and the top ones. I've mentioned before the top 5, but the bottom 3 certainly are significant and important, especially Guillemandii and Lusitania, which have some significant amphotericin resistance. And I'll touch on later about Candida auris, which is a multi-drug resistant organism. Obviously, there have been more than 600, maybe now closer to 1,000 cases throughout the world. So it is quickly becoming an important pathogen. Next slide. The antifungal resistance implications, certainly, although rare, we are starting to see some Candida. We've seen some Candida albicans. This occurs primarily in patients that have some underlying immune disease and are on long-term antifungal therapy. Candida glabrata has become very, very important and one of the very common pathogens with increasing rates of resistance, specifically to fluconazole and also to voriconazole. More recently now, we've started to see an increase in MICs to echinocandins because of the FKS mutations. There have been numerous reports now, especially more from Europe, about the increasing resistance to fluconazole and Candida parapsilosis, which is generally associated with line infections, central line infections, Hickman catheters, and ports. Candida auris, as I mentioned, is a multi-drug resistant. This from one of the latest studies that shows that 95% of the Candida auris are fluconazole resistant, 6% are fluconazole and amphotericin resistance, and although rare, on occasion, there's actually an azole polyene candin resistance, which occurs in about 1%. And certainly, everybody's aware of Candida krusei, primarily found in hematologic malignancies, which is one of the original, and it's one of the original multi-drug resistant Candida, not only the azoles, but some polyenes as well. Next slide. Candidemia and invasive candidiasis remains with high mortality rates, specifically the non-albicans. Compare that to the albicans, and we're talking about Candida krusei with mortality rates of about 60%, Candida glabrata in the 50% range, and even one of the pan-susceptible Candida tropicalis remain high. It's a pretty nasty pathogen at 43% combined mortality rate. So certainly something we have to take into account. Next slide. A few of the risk factors, and these are just a couple of them. The ones in yellow are ones that a lot of people forget about, specifically the C. difficile infection. A recent study that was published just a couple of years ago showed that about 10% of patients that had C. difficile infection also had candidemia to boot, possibly because of the translocation of the organism. Patients that develop acute renal failure and have to go on to dialysis have an odds ratio of 5.4, along with those that are mechanical ventilation more than 3 days at 3.5. And obviously, the top 4 ones are the ones that everybody's well aware of, specifically central venous catheters, prolonged ICU stay, hematologic malignancies, and broad-spectrum antimicrobials with odds ratios of 3.0. But be aware of the ones in yellow, specifically the C. difficile infection, which a lot of people are unaware of. Following slide, next slide. One of the problems we have with Candida is the diagnostic challenge. There are really no specific manifestations. It can be anything from fever to patients going into septic shock. The other problem is trying to define what is colonization versus infection in some of the patients that we have. Recognizing that blood culture positivity rates, although old data is somewhere in the 40 to 60% range, but that really depends on the individual, the comorbidities, prior antifungal therapy. So what are we left with? We're left with hopefully a high index of suspicion in these high-risk groups. And the key to this is the fact that there are no characteristic or pathognomonic manifestations of candidemia or invasive candidiasis. Following slide. So this slide kind of goes through the diagnostic modalities. And I mentioned number 1, high index of suspicion. Blood cultures are not very sensitive if we're lucky to get one, 20 to 70%, depending on the patient. Tissue culture for invasive disease, obviously, you have to have a biopsy. The beta-glucan or Fungitel, which has been used now for quite a few years, recognizing that it is a pan-fungal assay, not specific for Candida, and it has a sensitivity of about 85%, specificity in the 80 to 90%. The downside to this, however, is not readily available at most institutions, and it's frequently a send-out test, so it takes several days to come back, and that may be a little too late for some of these patients. The same thing goes through the PCR-based assays, have very different sensitivities depending on that. The fact that they're costly, and again, they have to be sent out, so most institutions do not have the availability to do these PCR assays. Following slide. Management of candidemia. Well, the key to this, recognizing that all fungal infections have a lot to do with underlying host and an antifungal. So removing the focus or source control obviously is the key. Removing or decreasing immune suppression, neutropenia specifically, patients that do not recover their white cells have extremely high rates of mortality above 80 to 90%. Somehow restoring the immune function, and more importantly, beginning adequate and appropriate antifungal therapy early, not waiting to initiate therapy until you have a positive blood culture. It may be too late by that point in time. Next slide. This is a study that was published actually in 2005 out of WashU in St. Louis that looks at these patients. And what it tells us is, real quickly, is delaying and starting an appropriate antifungal therapy of over 12 hours increases the mortality rate from 10% all the way up to about 30%. So essentially from this study, we have 12 hours or less to hopefully impact the mortality, morbidity, and length of stay in some of these individuals. Waiting more than 12 hours, once you get to 24 to 48, then we're in the range of standard candidemia and candidiasis mortality rates of 30 to 35%. As you can see here, most of the patients in these studies were not started on antifungals until after the 24 to 48 hour range. So something to bear in mind and to keep in mind if you're thinking of delaying therapy. Next slide. The election of antifungals, this remains the same, and it's actually been, it was actually published in 2016 with IDSA and MSG. Echinocandins are still the recommended first line if the moderate to severe infection, any prior azole exposure, and infections definitely due to Candida glabrata, Candida krusei, and also Candida auris, recognizing the resistance in these organisms. Next slide. What about the azoles? Well, they do remain the standard of care in many parts of the world, especially places that have limited resources because they can give it orally, or in places that have low azole resistance, frequently used as step-down therapy or de-escalation, if you will, and are some of the primary agents for meningitis, endophthalmitis, and urinary tract infections. However, recognizing the azoles have some significant drug-drug interactions, and the azoles also now we're describing as an increase in multi-azole resistance, not just azole, but multi-azole resistance. The following slide. Quality improvement issues, and there are some question marks here. These are published and recommended in 2016. Fundoscopy exam to rule out endophthalmitis. I have a question mark now because there's considerations and questions from the Ophthalmologic Society if the fundoscopic exams are actually needed in all patients with candidemia. So that's something that is going to have to be discussed. Do we really need daily blood cultures until they're clear to perform? Or can we go to every other day or every third day? Initiation of antifungal therapy is a definite positive, hopefully within the first 12 hours, if not the first 24. And then finally, the recommendation is 14 days of therapy after the blood cultures have cleared, but when there's no evidence of tissue or invasive candidiasis in that respect, so candidemia alone. Next slide. What about the febrile culture negative septic patient, right? So next slide. This is something that we see all the time. When do we start antifungal therapy? What antifungal do we start? Should we use or start empiric or early presumptive antifungals on everybody who have some of these criteria? Well, we don't really have any good definitive studies to tell us when we absolutely should start an empiric antifungal agents. Following slide. So again, recognizing that the longer you wait, the greater the morbidity, mortality. We have no specific manifestations. We don't have a great single sensitive, universally applicable test. And again, waiting for a definitive proof increases the risk of potentially fatal progression to disease, increasing morbidity, and certainly increasing mortality. Next slide. So this is an interesting study just to make sure what I mentioned before about waiting for autopsies. Retrospective study, it's not large, it's 100 patients in the ICU, published at Mayo Clinic Proceedings, and they looked at these 100 patients and guessed on the diagnosis antemortem, and they all had autopsies. So they actually were not bad. 81% of the patients had an antemortem diagnosis that was confirmed by an autopsy. And the most common cause of death was bacterial pneumonia with multi-organ failure. However, there were also certain misdiagnoses, and these were defined as class 1 errors, which means that if they would have made the diagnosis before mortality, it may have changed therapy. And the one there in the middle that stakes out is systemic fungal infections. 5 or 36% was the most commonly missed diagnosis in patients where maybe something could have been done, or an antifungal could have been initiated early on, followed by tamponade, abdominal bleeds. Class 2 errors, no effect on outcome, and that was really cancer and mesenteric ischemia. So again, recognizing that it's not uncommon to find these diagnoses during an autopsy. Following slide. So what about this early presumptive therapy? We definitely know we have studies to show that there's a benefit initiating early and appropriate. However, most of the studies evaluating identification of high-risk hosts have been pretty disappointing. We do have some prediction rules. What criteria do we use? How to identify these patients? Candidate scores, possibility, is something that's been published. The MSG prediction rules are other ones that have been published as well. But do we have a study that will help us initiate appropriate therapy? Not yet. I think it's something that still needs to be looked at, but these are difficult studies to do with a lot of patients that need to be enrolled. Next slide. So what are a couple of the unmet needs or unanswered questions? Well, number one, as I mentioned, is rapid and improved diagnosis, species ID and susceptibilities, improved criteria for initiating antifungal therapy, new antifungals effective against a lot of these multi-drug resistant candida species, specifically azoles and echinocandins. A question that I always ask the surgeons, and if you ask your surgeons, the treatment of all intra-abdominal candidiasis, does all candida in the peritoneal cavity need to be treated? Well, if you ask infectious disease and mycology, the answer is yes. If you ask the surgeons, including the trauma surgeons, it's a 50-50 split, because the fact that they think that once they irrigate the abdomen, they can get rid of the candida. What do we do with candida and a BAL? Well, usually nothing, and 99.9% of the time. But we definitely know from in vitro studies in our lab and in other labs that candida interacts with bacteria, specifically staph. And we know that there's a very important cohesion there between fungal and bacterial infection. And what about shorter treatment courses? Instead of why 14 days and not 5 to 7? And I've been looking at this and I've been discussing this for many, many years, and nobody's taken me up on the offer of doing a shorter course of treatment. Next slide. So a couple of take-home pearls. More common than we think, certainly candidemia and candidiasis. It still remains one of the diseases with high morbidity, high mortality due to poor diagnostic techniques, late antifungal therapy initiation, and the current management to reduce morbidity needs to include high index of suspicion in these high-risk patients, and certainly initiating early and appropriate antifungal therapy despite negative blood cultures at this point in time, since we don't have one. Next. With that one, I'd like to thank you very much. Hopefully it has been enjoyable and you have learned some, and I will turn it over to Dr. Ostrowski.
And next up, it's my pleasure to introduce Dr. Thompson from UC Davis, who's going to be talking about endemic mycosis. GR, take it away.
Thanks so much, Luis, and thanks to the organizers for the invitation to present perspectives on the endemic mycoses today. I was very pleased to see several of the endemics listed on the World Health Organization profile for these agents. Next slide. And here are my disclosures. None are particularly relevant. Unfortunately, almost all medical treatment for the endemic fungi is off-label use. Next slide. In the discussion topics really today for the endemic mycoses, the major changes and shifts we are seeing is the endemic ranges of these pathogens are clearly changing. They're moving farther north within the United States. They're moving east. There's clearly changing epidemiology for where these fungi are, but also the at-risk populations. And overall, I think we have a pretty poor understanding of the global epidemiology. I think a lot of us know our local epidemiology for these different infections, and we even do a pretty good job with regional understandings in the epidemiology. But I think the global epidemiology, we still have a lot of work to do. There's clearly high morbidity and mortality in certain patient populations with the endemic fungi. A lot of us that practice within endemic regions, this is a daily part of our infectious disease practice, particularly in our immunosuppressed patients. These can really just have devastating and debilitating consequences. And one of the biggest problems is there's really a lack of preventative strategies. Occupational health as probably the only one that's really moved forward in trying to think of strategies to prevent infection or acquisition of the diseases. But I think that one of the things we're going to see over the next decade with investments by numerous public health agencies is the development of vaccines to prevent endemic fungi. And I think that Coxie is a little bit ahead, and we're very much hopeful for a pan-endemic fungal vaccine. I think that there's been some work in Canada and Aspergillus with vaccination strategies, and hoping that those collaborations will continue and we can really make some headway in prevention of these. I think interferon gamma assays are really of interest and something I'll talk about in a few slides. Certainly skin testing strategies can be employed, and those are being done in some situations. And then one of the other big problems is we really have a lack of in vitro susceptibility studies that are predictive, that there's no breakpoints for the endemic fungi, and there's very few comparative clinical trials that can really guide overall management in the care of these patients. Next slide. So here, if we just kind of return to this list that was published by the World Health Organization and how they've ranked these different pathogens, I've circled the 4 endemics that are included here in green. Histoplasma species are included in this high-risk group. The medium on the far right would be Coccidioides, Talaromyces, and Paracoccidioides. And again, I think very important to recognize the global burden of these disease, but I think we still have a lot of work to do to fully understand that. Next slide. So if we look at the maps for the endemic mycoses, I think any map we present is almost immediately going to be out of date. There are new cases constantly found. You can see histoplasma in the top left here. There's a number of histoplasma species. All of the endemics, just like mycology, have undergone pretty significant taxonomic revision over the last few years. Histoplasma within just the United States, capsulatum certainly is there, Mississippiense, Ohioense, Suramericanum, and Dubosii in Africa. And then Coccidioides on the right here, so really 2 species established, which are Posidacea in orange and Immatus in yellow there. Those are clearly moving north and east within North America. There's probably 5 species of Coccidioides, and I think that work will be presented later this year in April. And in the bottom left, you see Paracoccidioides and kind of the established endemic regions for that infection. But the problem with Paracoccidioides is we do see cases that have traveled, right? But those certainly are not listed in the United States or anywhere else in North America or throughout the world in this slide. So we really don't know how many cases are presenting in other locations. And then in the bottom right, you can see Talaromyces, so very endemic within Southeast Asia, a tremendous problem for the immunocompromised patients there as an opportunistic infection. And on this figure, yellow is imported cases within Japan and Australia. So these infections are clearly increasing. They're clearly expanding their regions of endemicity. There's been a lot of talk about is climate change responsible for that? Is it our growing immunosuppressed population? And I think only through big, large-scale studies is our epidemiology and understanding of the patients at highest risk going to be improved. Next slide. So we'll go through these one by one, and I've tried to just put in some sort of take-home points since it's difficult to go through 4 fungi in just 20 minutes. But for histoplasma, I think a lot of us in the United States have a very US-focused view of histoplasma, and I think that's really incorrect. And it's important for us to remember that histoplasma is a global disease. And again, numerous species responsible for disease. There's some thought that the Central and South American version, the Suramericanum, is actually more virulent. I don't think that's been definitively proven, but I think that there certainly are differences in the species of histoplasma responsible. It probably doesn't make a big deal for histoplasma antigen testing. I think that's very limited so far, but important to consider that different species may have slightly different sensitivities of antigen tests, but again, not definitively proven either. But the global burden of histoplasma is significant. I mean, we think again a lot about the US cases, but Brazil really has the brunt of disease. And then there are autochthonous cases reported in Europe. I think this Italian report from several years ago has really shown that. There's other reports certainly from Western Europe, and I think that it would be great to include those to really refine our understanding of this disease. Throughout equatorial Africa, that's primarily Histoplasma dubosii, but in South Africa, it's capsulatum. So I think, again, really important to understand the epidemiology and where these diseases exist. Next slide. So from the WHO report, the World Health Organization report, again, it really emphasizes this as a global disease, and it has a tremendous impact on our immunocompromised patients. It's often the presenting manifestation of HIV, particularly those who've come from Central or South America, at least at our clinic. They are diagnosed with disseminated histoplasmosis and then found to also have underlying HIV or AIDS. Certainly in the Midwest and other locations, malignancy and transplant, histoplasma is a huge problem for those patients. Very high associated morbidity rate, difficult to treat in a lot of those circumstances, and really take a lot of time and healthcare resources to take care of those folks. Mortality rates are really best described in the HIV and AIDS population, and you can see here just still substantially high, 21 to 53%, so a tremendous burden of mortality in those patients. And again, a lot of these patients present with very late stage AIDS, and histoplasma sends them to the ICU and have a fairly prolonged stay trying to recover from that. There's lower rates in other immunosuppressed groups, and I think that's probably a surrogate of those who are linked to care. I think they are diagnosed a little earlier. And then children, the reported mortality rate's only 2.7%. But as you'll see over and over in all of the endemics, our understanding of these diseases in a pediatric population is really lagging behind that of the adults. Length of stay for hospitalization is typically 5 to 7 days, but those with more rare manifestations, such as histoplasma meningitis, the average length of stay for those patients is at least a month. So it's a tremendous burden on the healthcare system. And again, the global incidence is unknown. Prevention, I think that a pan-endemic vaccine really is possible. A lot of these different endemic mycoses do share gene orthologs, and with mRNA technology or other, I do think we're going to see a pan-endemic vaccine be presented for potential clinical trials over the next 5 to 6 years. And I think that would be great. Other prevention is certainly interferon gamma assays. I think that just like we do for tuberculosis before we immunosuppress our patients, I think in the endemic regions, this would be good to test our patients for histoplasma before we immunosuppress them. It would really decrease the ensuing morbidity, and hopefully we can have more of a prophylactic strategy for those. The other factor for prevention that's really not discussed in this report, but I think is of interest in high-risk settings, is to employ a strategy that's a little bit more like cryptococcus, or patients at high risk are tested periodically for cryptococcal antigen, and those that are positive can be tested preemptively before they develop significant symptoms. And I think in very hyperendemic regions, in immunosuppressed patients, that may be a viable strategy, and there's ongoing work in that area. Next slide. So just to zoom in a little bit on the changing epidemiology of histoplasma, you can see here, this is between 2001 and 2012, and HIV, the incidence in HIV is held fairly significant, but has declined over more recent years. Those patients with diabetes are kind of this darker gray box, and our diabetic population is clearly increasing and aging. Histoplasma is increasing in frequency in that particular patient group. And then those with conditions treated with biologic agents, that's this light gray box. You can see that group's clearly increasing over that decade's time, as well as in transplant. That's both solid organ and hematologic bone marrow transplant patients. So those are the two groups where there's really been the biggest increase in incidence of infection, but all four of these groups really make up the significant amount of disease. Next slide. So from this report, the clinical and research needs, they really emphasize that large-scale epidemiology studies are needed. I think that's going to take a wide-scale collaborative effort to do that. Really, access to diagnostic tests varies significantly between different centers and where you practice. There is a lateral flow assay, is employed in quite a few locations, but not uniformly available. And then treatment is low. Histoplasma is probably the one endemic mycosis that we know a lipid amphotericin product is better than conventional amphotericin. And lipid drugs are not widely available in resource-limited settings. And certainly itraconazole, which is what the majority of these patients are on, is also expensive and not widely available either. In vitro breakpoints are not available. There's not been a lot of work done in resistance with histoplasmosis. There has been some, there have been a couple papers published, but I think still some additional work is needed. And they concur with that and really list additional in vitro and even synergy testing be performed for evaluation of histoplasma in the in vitro setting. And then preventative measures, and I listed a few of my thoughts here as far as vaccines and interferon gamma assays and the way we could potentially employ those. Okay, next slide. Okay, so we'll move on a bit to coccidioides and the key World Health Organization findings for cocci. I was very pleased to see in one of their first lines, they do call cocci one of the most virulent fungal pathogens. And if you've not had a lot of experience with cocci, I think that's great. These patients take an enormous amount of time. They're typically not immunosuppressed. They often have genetic reasons to have bad cocci, which are only recently being elucidated. Risk factors include those of African genomic ancestry. I'd also add oceanic genomic ancestry. So those from the Philippines, Marshall Islands, they do seem to have a little bit higher risk of dissemination. Also, age is a significant risk factor, as are occupational risks, anything that has a lot of soil exposure. We see those in certainly construction workers, those that work on train and rail lines. And mortality rates, they list in this report as 2 to 13% in selected populations. I'd say that the mortality rate that's more recently published is a bit higher. If you have disseminated cocci, your mortality rate's about 15%. And meningitis, even in the antifungal triazole era, is still about 30% mortality, which is a huge improvement from the pre-azole era when we knew they had 100% mortality at 2 years. But I think that this report actually underestimates their overall mortality. Length of stay is significant at 3 to 7 days, median of 22.7 days in those with meningitis. And again, the global incidence is unclear. Cocci is clearly moving throughout North America. It's moving further north and east, and it's not uniformly reportable within the United States. So I think we don't have good epidemiologic data for this in several of the states within the US, and then certainly within Central and South America, we really only have the very tip of the iceberg phenomenon for how many patients have cocci in those locations. Prevention of disease is very difficult. A lot of these at highest risk, those again in construction settings, do not want to wear masks to prevent acquisition. It's just too hot for them. There's currently a lack of vaccine, although there's 3 potential candidates in development. Very unclear geographic risk, which I'll talk about really on this next slide here. We could screen patients more aggressively, and certainly very similar to what I proposed for histoplasma before they have any immunosuppression, certainly screen those patients. And then access to diagnostics is not uniformly available depending on location. Next slide. And here's really the 2 main things that are received a lot of the attention in the field of cocci of late. So this paper on the left was published by Morgan Boris in GeoHealth in 2019. And I actually met this paper with a lot of skepticism when it was first published. You can see under these different climate change scenarios are what the authors have postulated. And you can see kind of this by county level on the top left in 2007. Those are the areas within the United States where there's cocci. And under a moderate climate warming scenario by 2095, you can see it's all the way up in the Dakotas, really has established itself in Idaho and some other places where we're not used to thinking about cocci. And then under a high climate warming scenario, all the way up to northern United States, which means it's also going to be in southern Canada. And again, I didn't think this was probably accurate. I thought this was probably a little bit over aggressive in these estimates. But over the last few years, we've seen cases in non-travelers in Missouri. There was an outbreak last summer in Nebraska of 18 people who had not traveled that had coccidioides. So we may already be seeing this much, much earlier than we anticipated. And I think I now accept this paper as a little bit more of a call to action. On the right side, you can see really the in vitro susceptibility of coccidioides to different azoles, as well as the echinocannins, which should not be used as monotherapy or really at all for most cases of coccidioides. But you can see in blue here, fluconazole has very high MICs, and that's one of the reasons we think that high fluconazole doses have been required in the treatment of coccidioides. And then these patients fail fluconazole, they often do respond to the other azoles. And we think that this in vitro data at least gives some credence to that hypothesis. Next slide. So what they recommend from this report is really to do large-scale epidemiology studies, and we've actually called on that in a number of papers over the last year as well, to make this a reportable disease, really to increase access to these diagnostic tests. There's a number of new tests available, additional assessment of drug resistance, and I think that the NIH has been very supportive of that with a number of U19s, and one of those is looking at drug resistance. Cohort studies evaluating outcomes. I think there's some groups that are really interested in that and trying to accumulate data, really solve that problem, particularly in the pediatric population where very little data is available. Prospective studies to really look at these in vitro results with outcomes that would help us establish breakpoints for at least one of the endemic mycoses. And then comparative trials, and there's really only been one comparative trial in coccidioides, and that was itraconazole versus fluconazole, published about 20 years ago. Next slide. So to move on to paracoccidioides, the key findings from this, really the risk factors are age and male gender. Paracoccidioides has this very interesting predilection for the male gender. Mortality is pretty significant again, primarily in those with HIV or other immunosuppressed populations. And then length of stay data is just not available. We don't know how long these patients are in the hospital, what type of healthcare resources they're using. Complications of adrenal insufficiency and lymphedema are significant. The global estimates of incidence, again, not available. We don't even know how many paracocci cases are in the US. Prevention is low. Again, no vaccine is available. Diagnostics, most of these are diagnosed by serology within South America. Access to that is moderate. And then availability of treatment, again, is very low and resistance is unknown. Next slide. So from this, the World Health Organization really calls for trying to understand morbidity and mortality estimates for this disease. Again, we don't know the length of stay and long-term complications. There's really not been antifungal susceptibility testing updates in the last 10 years. It would be nice to look at some of these new species that have been published as the taxonomy has changed to make sure that at least in vitro, we think these drugs are going to work. Global surveillance outside of Brazil is really in its infancy, and our understanding of risk factors and prevention strategies also lags a bit behind other areas of mycology. Next slide. And then just to finish up with Taloromyces, again, this is a significant opportunistic infection within Southeast Asia in our HIV population, also cancer and transplant, very high mortality rate, 12 to 21%, long length of stay, about a month of hospitalization for these patients. And there are significant accompanying complications with respiratory failure, immune reconstitution, inflammatory syndrome, and wasting syndrome. The global burden really cannot be assessed. Some of these countries don't have data quite accumulated yet to share and really see what the incidence is in these locations. Preventative strategies are pretty low, no vaccine available again, access to diagnostics is moderate, availability of treatment low, and no breakpoints for this. Next slide. But one of the things that I think Talaromyces really has led the way is it's one of the very few comparative trials in all of the endemic mycoses. This is a study by Thuy Lee, who's at Duke, published in New England Journal about 5-6 years ago. It's an open label non-inferiority trial that again really shows that we can do this in the endemic mycoses. And this compared conventional amphotericin B deoxycholate to itraconazole as induction therapy. And what they found was the risk of death at week 24 was substantially decreased in those receiving amphotericin product. Also associated with faster clinical resolution and fungal clearance. And I think, again, really puts forward the idea that amphotericin is the standard of care up front for these patients, but also that we can do these studies. They're difficult to do in the endemic mycoses, but they should be done. And this is clear evidence that they can be done. Next slide. And then here's a patient, just if you've not seen one with Talaromyces, this patient's obviously recovering. His skin lesions have started to scab over. But prospective outcome studies for both mortality and morbidity really are needed. We do need antifungal susceptibility on a large group of isolates to correlate in vitro results with outcomes. Active surveillance really for the global distribution. Again, we don't know for this disease, just like the other endemics. And it'd really be great to have some outcomes data on non-HIV AIDS patients and agree with what was proposed in the reference document. Next slide. So to summarize, it's obviously difficult to go through 4 different fungi in 20 minutes, but a lot of similarities within the endemic mycoses. We don't have a good understanding of the global epidemiology. We don't have great outcome studies or comparative trials. Our understanding in the pediatric population in particular is lagging behind. Susceptibility testing and large-scale testing needs to be performed. And then preventative measures, and this is where I'm hoping we do see the field go over the next decade, is really prevention, skin testing, vaccination, interferon gamma assay development. And then can we make a pan-endemic vaccine that would work for all of these? That's a much bigger market and a more viable platform for industry to respond. So thank you so much for your time and happy to take questions at the end.
And now for our final speaker of the day before our roundtable, it's my pleasure to introduce Professor Sharon Chen, who's joining us from Australia today. Sharon, take it away.
Thank you, Luis, and thanks to the MSG for having me on board. I won't be speaking on any particular studies because Aspergillus and a whole list of moles in 20 minutes is a huge task. So what I thought I'll do is to provide a perspective on the WHO fungal priority pathogen list and hopefully won't be misrepresenting the views of the MSG. Next slide, thanks. These are my disclosures, and I would add that I was not part of the Sydney group that was on the review list for the pathogen list, and therefore I have a completely unbiased view. Thank you. Next slide. So for discussion today, what were some of the key findings from the WHO FPPL? And this I've taken from presentations given at Isham last year and local meetings. And as Anna has so elegantly outlined, these were developed using predefined criteria, and these are important in coming up with their list. So mortality, what happens to people in hospitals, complications and sequelae, which is something that we often forget about, in vitro susceptibility, risks, preventability, incidence, and frequency. So here we will provide a perspective from the MSG, focusing mainly on invasive aspergillosis because this is the most common mold pathogen, and focusing on clinical needs and research. Next slide, thank you. So we've seen this list before, and I've just singled out the Aspergillus fumigatus, which is in the critical group. The high group includes Mucorales and Fusarium species. And I was a little bit disappointed. The 2 of my, favorite pathogens were in the medium group. And I guess this emphasizes the need to recognize the geographic variation in incidence or frequency of pathogens that we might see. And we should also note that Cryptococcus gattii, another of my favorite pathogens, is only in the medium group. Next slide, thank you. In talking about Aspergillus, and I've confirmed this with Justin Beardsley, it was really talking about A. fumigatus sensu stricto, so the real McCoy, and not about other Aspergillus within the A. fumigatus species complex, which we know and recognize to be more drug resistant. So we have the Lentulus species, the Fischerana species, and Fumigatinus affinis species, which we're seeing more and more, but which were not part of the WHO recommendations and not part of the talk this morning, this afternoon. Next slide, please. So what are some of the key WHO findings? This is a mix of what's been presented before and some of my own thoughts. We all recognize that Aspergillus fumigatus is highly relevant to humans, to animals, and it's found in environments. And I've been told that in only 49 articles on invasive aspergillosis were analyzed and taken into the final analysis. I would guess that mortality, looking at one of the criteria, would vary because we know we measure mortality at 30 days, 42 days, 100 days, 12 weeks, which is 90 days. We look at azole-resistant species versus non-azole resistant, and COVID certainly has confused the picture, well, added to the picture in the last 3 years. Length of hospital stay, like for the endemics, pretty hard to find data on this. And when I last looked, I could only find one study that looked at length of hospital stay published in 2018. And certainly very few data on excess length of hospital stay related to invasive aspergillosis per se, or indeed length of stay variation in subgroups of patients that we might be interested in, for instance, cancer patients. There are also very few data on complications or sequelae of invasive aspergillosis, and we know that this can occur late down the track when patients are discharged from hospital, but it's difficult to pinpoint the types of complications or the frequency of complications. Azole susceptibility rates vary with study and geography, and when I last looked, across the 20-year period or so, it ranged from 9.6% to 100%, depending on which study you read. There's cross-resistance to all the azoles, and WHO identified an increased rate within the time frame of the review in only one study. We're familiar with newer host risks now with viral co-infections, Kappa, flu, and confounders that we see with many mold infections and yeast infections such as diabetes, COPD, end-stage kidney disease. I would hazard a guess that the annual incidence found by the WHO would have widely ranged with varied denominators, including for Kappa, with the most robust data being found for acute leukemia, because this is the one area that has been most well studied in invasive aspergillosis, that and BMTs. And of course, we know that invasive aspergillosis is globally distributed. Next slide, please. So what are some of the clinical and research needs? Well, mortality measure, if we are going to be able to talk to one another and design clinical trials and have comparable data, then we perhaps could think about the types of mortality we want to measure. All cause, at what time point? At 6 weeks and 12 weeks, like we do for clinical trials? Should we standardize these mortality endpoints? And do we need different mortality endpoints for different patient populations? And what are the trends over time? And what about attributable mortality? Very difficult to measure because you need to kind of go by the DRBs and have standardized definitions. Otherwise, the critiques that may confront us when we try to estimate this could be pretty much insurmountable. Excess costs due to IA economic studies, like we have for Scedosporium and Lamentaspora, are not found in invasive aspergillosis. Longer-term outcomes and resistance studies. We perhaps need more studies outside of Europe and the USA and identify barriers as to why studies are difficult to do in countries outside these areas and link these studies to outcomes. Next slide, please. These next two slides just show a summary of the more recent studies on azole-resistant rates in clinical A. fumigatus isolates. So the studies I picked were from, say, 2016 to 2022. And in Europe, you can see that the frequency or prevalence is probably the highest, but not as high as I thought they might be. So ranging from 3.3% in Turkey to a high of 9.2% in a recent study in the Netherlands. And this is where the initial reports came up from, as well as from the UK. Some of the studies were national studies, some were single center studies. Most of them looked at mechanisms of resistance unidentified. The TR34 resistance mechanism, which is associated with environmental azole exposure and environmental resistance as well. In America, there is a recent study published by Badali et al. In 2022, reporting a prevalence of 3.5%. Again, this was a multi-center study, and the TR34 and TR46 contributed to the mechanisms of resistance. Next slide, please. Moving to the Asia Pacific with a few Chinese studies, the Taiwanese studies, and one from Australia, and looking at a slightly lower prevalence rate. Again, single studies, single jurisdictional studies, and very small numbers of isolates looking at the mechanisms of resistance. So it's there, and we should be vigilant, but identify barriers as to why larger studies may not be able to be performed in certain regions. Next slide, thanks. Agricultural countries are reported to have the highest prevalence, and even then there is uncertainty over the reasons for azole resistance, such as what sort of pesticides contribute to azole resistance. Is every use of pesticide equally harmful? What do we do about the lovely tulips in the Netherlands and azole composting? Do we want to see this, or do we want to see that in the off-season? What with the newer ipflufenoquine, which is a DHODH inhibitor, and how to work with the agricultural community into having a balance of how much composting we do with drugs and the need to take care against fueling antifungal resistance. We certainly do not want the newest olorifim to become at risk of not working in patients when when there are already very few new anti-aspergillus drugs, and certainly a One Health collaboration is needed. Next slide, please. So continuing on the thoughts of clinical and research needs, apart from the azole resistance question, looking at new risk groups, so flu, COVID, patients on Bruton kinase inhibitors, surveillance. We've talked about this with Crypto Canada, the endemics. This also needs to be encouraged in aspergillosis, and the denominators need standardizing. I think one of the largest areas identified by WHO and certainly by other groups are in the prophylaxis and treatment guidelines outside classic high-risk patients and outside invasive pulmonary aspergillosis. So what do we do with CNS infection, bone and joint infection? And what do we do with solid organ transplants, ICU patients, and other risk groups? So I don't have any answers this morning, but just put it out there for every one of us to think about it. And there's the question of primary disease and breakthrough disease. Do we need different prophylaxis strategies and different treatment guidelines for these two entities? Next slide, please. This is the third slide on clinical and research needs in invasive aspergillosis. Finally, we need oral treatments that are fungicidal. Azoles are static. We do have olorifim now, and it remains to be seen how that pans out in the next 5 years or so. When doing clinical trials and clinical studies, what is the best time to assess treatment response? We are informed again by invasive pulmonary aspergillosis and in stem cell and acute leukemia patients, but would that one-size-fits-all patients group, would shortening the time to response assessment be useful? And what do we mean by a response versus stable disease? Is stable disease, does it equate with failure for all the different forms of invasive aspergillosis? And to bring home this thought, can we apply this response definition to all hosts? So solid organ transplants versus your classic hematology patients versus ICU versus other groups. Next slide, please. Moving on to the remaining moles, I would hazard a guess again that the needs are similar as invasive aspergillosis, but because the burden is less and the data are fewer, the enabling these needs may be more problematic. And I would briefly talk about the mucorales, where the needs are Fusarium, Scedosporium, and Lumentospora prolificans. Next slide, please. Host risks. Let's move beyond the classic hematology group of patients. So for mucorales, do we need more studies in diabetic patients? And, they get ROCM as opposed to invasive pulmonary aspergillosis. Are they different? What about burn and trauma patients? And this not only affects mucorales, but Scedosporium and Lamentospora prolificans as well. What to do with the cystic fibrosis patients? They're colonized with many moles, and then they get offered for lung transplants. And post-lung transplants, you get colonization and get infection with moles as well. So these are the 4 perhaps key groups for future studies to focus on. Next slide, please. In CF patients, 28 to 49% have fungi in their sputum, and it varies greatly depending on where you are. The most likely colonized with non-fumigatus aspergillus, Fusarium, black moles, Scedosporium, Lamentospora prolificans. Can we use performance of biomarkers to track these colonizations of infections? And infections in CF patients, as this audience knows from speaking with their respiratory colleagues, is that the definition of infection differs from the classic ERTC MSG criteria. Colonization may equate to infection. These patients are also exposed to antifungals, leading to the theory of azole resistance. There are PK issues. And why is this important? Why do we worry about CF patients? Because most patients will be listed and receive bilateral lung transplants, and then it will be an ID problem in a transplant population, transplant physician population problem. Next slide, please. Mucormycosis, the additional needs. There are no randomized controlled clinical trials, and currently we are, comfortable with using amphotericin B formulations, lipid formulations in the initial phases of therapy, followed by step-down isavuconazole or posaconazole. Do we need new trials or open-label studies? And what is the optimal timing of step-down therapy? What does clinical response mean in the different groups of patients? And again, maybe separate out the hematology oncology patients versus other groups of patients, such as diabetes. Can we assess rhino-orbital cerebral mucormycosis the same way as we do with other forms of mucormycosis? Perhaps case-controlled prospective studies are needed. And combination therapy, this is typically used late in the game when I last looked, and perhaps this should be stepped up or considered stepping up prior to patients not responding. New slide, please. The likelihood of RCTs are even smaller for non-mucorales and common mold pathogens, such as Scedosporium. And mostly they are open label studies and salvage therapy studies. And the timing of enrollment is problematic because we wait until patients fail before being able to enroll these patients with a better or alternative drug that might hold more promises. So what are the purposes of doing these trials in this group of patients? Could we consider adaptive trial designs, even with its cons, and have a different approach to uncommon mold infections? Next slide, please. We are familiar with the new antifungals. We are familiar with alorifim, which is the first-in-class erotamide, which selectively inhibits fungal DHODH enzyme and stuffs up its pyrimidine synthesis. It's fungicidal, and notably, it's active against Lamentospora, Scedosporium, Aspergillus species, including azole-resistant Aspergillus, but it has no activity against the mucorales or against yeast. The phase 2 open-label study is concluding or has concluded, and RCT on aspergillosis is recruiting. I think it's in Asia Pacific and it's in the US, if I'm not mistaken, and the real-world data managed access program is in the wings. Next slide. Thank you. And this is near the end, so we have another new antifungal, which other speakers have touched upon. It does have activity against Aspergillus and rare moles, and a phase 2 trial is now enrolling for invasive mold infections, including in COVID-19 patients. And I look forward to seeing the results of that study very, very shortly. And next slide, please. So the messages are then to focus on the unmet needs, like for the other pathogen, surveillance and estimating burden is critical. Broadening trial eligibility criteria to include specific populations is also very important for invasive aspergillosis, as in the other molds. Look beyond the hematology oncology patients. Look beyond the non-pulmonary sites and include sanctuary sites, children, breakthrough infections. Function of the MSG, well, they've done such a good job in updating definitions with regards to identifying patients with IFD, with regards to updating host inclusion criteria and biomarkers. I think they are in the process of updating the response definition criteria for mold infections to be more realistic and to achieve endpoints based on specific pathogens on host groups. And like today, to promote discussions like this, which I think are invaluable. And with that, thank you very much. Happy to answer any questions in the chat.
And now it's my pleasure to turn over the meeting to Dr. Pappas, who's going to coordinate the roundtable. And again, we want to encourage all the participants to ask their questions in the Q&A function. Pete?
Yes, thank you very much. I've been writing down some questions, and many of my questions are the same that have shown up in the Q&A. But let me just start. Let's start I'll start at the top with Anna. One of the themes here, and it's been asked by a couple of people, but each of you mentioned this, is the impact of climate change on the geographic distribution and maybe even the virulence of these organisms, and maybe even the emergence of really new pathogens. Can you provide me with any, or could you provide the listeners with any kind of evidence other than just kind of observational, intuitive type of data that suggests that climate change is really impacting these organisms? It certainly seems to make sense, but are there hard data to suggest that?
Yeah, thanks, Pete, for this question. I'm not aware of that, but mainly there are several voices that have raising these points, which I think, as we all agree, that makes some kind of sense. And it's also because we know fungi adapt to any completely different and extreme conditions. So, and we can see that maybe including this pressure on them can make some of them be, for example, more thermotolerant, and that we know that thermotolerance is one of the main things for not all the fungal to be infectious in humans. So my response is no, I cannot provide you with solid data, but I think it's something that we will see in the future, and it's probably a hot topic that we all want to bring it up because we think can make a big difference, but I'm not aware of any solid research study that can really affirmate that this is going to be the case.
Okay.
But I might be not current on that.
But as a follow-up question, other than Candida auris, where there does appear to be at least observational evidence that these pathogens co-emerged globally, are you aware of any kind of new or emerging pathogens that seem to be connected to climate change at this point?
Not really.
Okay. Well, open question to all of you, including Luis. Are you aware of anything that suggests the emergence of a new fungal pathogen? I know that our colleague at Johns Hopkins, Arturo Casadevall, has been hypothesizing this for some time, that thermotolerance, et cetera, is going to lead to the emergence of new yeasts and molds as pathogens. And it makes sense. I'm just wondering if we've observed this outside of Candida auris, where I think it's hard to explain the emergence of Candida auris as it has, with it not being somehow connected to climate change.
Well, I really think there's a lot of work to be done here. Obviously, the Candida auris hypothesis is really interesting and really feasible, but to my knowledge, they haven't really proven that conclusively.
Yeah.
I really like the story of Coxie for climate change, where it's getting warmer. There's more storms and winds. Soil is disturbed, and we're seeing Coxie in areas where we don't normally see. And I think this is more of a story of climate change than others. But definitely, this is a very fertile area for research and an area where we need to do a little more work.
Okay.
So this is Joe, Pete.
Yeah, go ahead.
So I guess I have a question. When everybody talks about climate change, what does that mean? Is it temperature changes? Is it CO2 changes? What are we talking about when we say climate change? I do agree. I think the other good one without climate change is maybe, what about cryptogadii? That kind of started up in, the Vancouver Island area. And I think they haven't. I think you see it now in Texas, right, Luis? Or there's some in Texas or stuff. So we saw one in Michigan when I was in Michigan. So how does that get around? So I guess I'm always confused when people want to blame everything on climate change when I don't really have a definition of what climate's always changing. But what does that mean?
Yeah, it could be rainfall. It could be
right.
a lot of different things.
Yeah, sure. Temperature changes. All sorts of things.
Let me ask Anna another question. This just came up, and it's just if you don't know, that's fine. But question came up from Sean Zhang at Hopkins. Why wasn't blasto included in the list of endemics? Were there proponents? Was there any argument over blasto? Was it just a little too uncommon to include it in the group?
Yeah, thanks for that question. I think everybody can argue why my fungus is not there, and I have been getting all these questions so many times, So if being frank, at the beginning, we started with 5 pathogens. So we really had to fight a lot with the expert group and everybody to include most of the fungal infections. And at some point we have to limit. We could go up and up and up on the number, and we decided to include mainly the ones that has high burden. For example, at the beginning we started with problems with antifungal resistance. So Candida albicans was not there. Only azole-resistant Aspergillus fumigatus was there. Things like that. But at the end we realized no, there are many problems as Joe has shown. For example, Candida, despite being susceptible, mortality rates are very high. So there's of course no clear reason, and we don't have a criteria of how to include, which to include and which not, and we just simply could not include more. And mainly we had like a burden, some number of infections, antifungal resistant problems. Also, we took into account if they come from regions in which there is a very limited infrastructure. So, for example, Thalaromyces is something that we don't know if there are a lot of numbers or not, but it's certainly restricted to an area in which there is a lot to be done there. And we thought that it would be interesting to put it there because of increasing the number of funds to that. But of course, we could include blasto and all other Aspergillus. Only fumigatus is there, for example. It's right. Even more striking that we could not. But as I was saying at the beginning, it was mainly azole-resistant Candida, Candida auris, azole-resistant Aspergillus fumigatus, and doubting if Fusarium, Mucorales, and so on. So. Okay. Yeah, I think there will be iteration in the future, and probably some other pathogens will be included, and other can be out of the list. So. Okay. There's no clear response.
The last question regarding this is, would pneumocystis fall into the same category?
Sorry?
Would pneumocystis fall into the same category then as, with same consideration with pneumocystis, just didn't make the list. There are other priorities ahead of
pneumocystis is on the list.
Oh, it is on the list.
Yeah, it's in the last. It's at the end of the list, but
I missed it. Okay.
Yeah,
okay.
it is on the list.
Congratulations. Yeah. Okay. All right. Joe, I want to ask you a couple of questions, and these are. I'm sure you've had to answer these questions before, so you should be very well prepped for this.
If not, I might.
Yeah. The first and the question that we are all getting. Especially in places like mine where we see at least as many non-HIV patients as HIV patients with crypto. What are you currently telling individuals about the ambition data and the ability to extrapolate those data to non-HIV infected hosts?
Yeah, so I think it's a difficult question. So in the context of HIV, as I was alluding to, I think an HIV positive individual with crypto in the States and an HIV positive individual with crypto in Uganda or South Africa could be treated the same. I would be happy using the ambition regimen in that context. Now, outside of the context of HIV infection, I've always been very reluctant to directly extrapolate those data because the pathophysiology really is quite different. In the context of crypto, we're dealing with people with virtually no immunity. We see very little inflammation. We're just trying to kill the organism and then reconstitute their immune system. Whereas in the context of HIV negative individuals, it's quite a spectrum of disease. And as you know from a lot of Peter Williamson's data, he's seeing quite a lot of excessive inflammation. He's suggesting that actually giving steroids could be beneficial in some of those patients, that the management may be quite different. And traditionally, we've given much longer courses of amphotericin treatment in those individuals. So you may be more worried about cutting back the treatment duration. But at the latest crypto conference, Peter Williamson was giving some very interesting thoughts on this, which is that actually much of the reason we give very long courses of ambisome in the context of HIV negative crypto is because people have been taking a long time to recover. We've been thinking that that was possibly due to slow organism clearance, but actually if that's all due to inflammation and the treatment for that is steroids, maybe those long durations are not really necessary. Maybe we could apply the ambition regimen, but I think we need more data before we can do that because there's such different patient populations.
Okay.
Can I have a follow-up question to that, Pete? Because
no, you don't get any follow-ups.
okay, fine.
No, go ahead.
Because we discussed that here. I mean, I'm in Augusta, which is a city of 500,000, but as soon as you drive 10 minutes, you're out in the country. And we have a lot of referrals, HIV patients with crypto. And it is tough, even with these folks, to try to get them out of the hospital. And it's one of the things that we've discussed. So do you feel comfortable here in the States, Joe, using it in HIV positive and cryptococcus here?
So, I mean, I would feel comfortable, yes, because we've got good data from our phase 2 early fungicidal activity studies showing that the rate of clearance of infection is as good with a single 10 mg per kg bolus as with the conventional treatment.
Right.
We've got data in a far sicker patient population from our African context showing that we saw 0 cases of culture positive relapse after the abbreviated regimens.
Yeah.
And so given both of those factors and the fact that we're seeing less toxicity, which of course is relevant everywhere, that there are major cost implications, even more so in a setting where hospitalization is very expensive, that I think I would be comfortable with that regimen. I think it's a very fungicidal regimen. I don't think that there's any benefit really to giving the conventional dosing over that.
Yeah, I mean, we have an issue because our hospitals are all clogged up, obviously, especially now, trying to get the patients out sooner, right?
Yeah.
Diminishing for us length of stay is really, really important. So if we could do that, that would be a game changer for the hospital.
Yeah. So we, in our trial, of course, we protocolized the duration of hospitalization because of, it's the first time it had been done. We had to be very cautious and for safety reasons. So we insisted that everybody stay for at least 7 days. Our median duration of hospitalization was actually 12 to 13 days, just reflecting that many of these patients, of course, are very sick. A lot of them do need to stay in for pressure management, for other opportunistic infections. But there's definitely a not insignificant proportion of patients who are well enough to go home on day 5 or day 6 or day 7. And of course, being able to clear those out a week earlier from hospital is a major bonus.
Yeah.
Okay. I'd like to get to the other speakers, but Joe, I have one other question for you real quickly. Have you had how much success? I know that you and Tom and the others have really tried hard to make flucytosine accessible in developing economies. How successful have you been in that regard? It looks like you've made significant inroads with ambisome. How successful have you been with flucytosine?
So I think that it's a long game, but we're getting there. So we've had some major successes in that arena. We've now got generic manufacturers making it. The price is almost halved. It's been registered and is now widely available in South Africa, which is the major gateway market, if you like, in Africa. And we're seeing access in 5 or 6 other African countries through initially some donation programs, but I think that will be sustained and that in a few more years' time, we're going to see much wider access to flucytosine. So I think we're getting there slowly, not fast enough, but it's happening.
All right. Joe, I have one question for you, and then I want to ask Sharon and GR question. I'd like you to just comment real quick. If you did not have, since you don't have a clinical trial right now where we can randomize people to 2 weeks or conventional therapy versus, say, 1 week therapy, do you think we could do an observational trial or a trial where we just approach individuals and offer them the opportunity for short course therapy provided they meet certain criteria?
Yeah.
Number one, do you think that's possible? And number two, what are your criteria for short course therapy? Real quick.
So it has to be. So yes, I think we could do that. Obviously, I've been trying to do it for about a decade, maybe. But number two is criteria would be, it's got to be a what's so-called uncomplicated candidemia, right? Where we think it's not from the belly, but it probably came from the line. Patients are reasonably stable. And the patients are hemodynamically stable at the same time, but with a follow-up, right? I think would be the key. So I think there's criteria of stability. And I think the other thing would be making sure that I've always thought about this, is repeating the blood culture, maybe 48, 72 hours, or getting a rapid test in 48 to 72 hours. And if it's negative or going down, then I feel comfortable. I mean,
what about a negative fundoscopic exam before you could be on short course therapy?
Yeah, I mean, that would be debatable nowadays, right? With ophthalmology.
Not with me, it wouldn't be.
No. But I think it's not a bad idea, because we definitely don't want end organ damage, right? Or end organ infection.
Right.
So I would say that would be a criteria if you have a negative fundoscopic. So it had to be kind of like when we do Staph aureus bacteremia studies, an uncomplicated infection with no signs of invasive candidiasis in a patient that was stable. And there's many of those that are line related that well that you pull the line and 1 or 2 days later the blood culture is negative even before starting an antifungal, right?
Yeah.
So who knows how many we could treat without an antifungal? Not that I would do that, but it certainly happens very frequently.
Okay. GR, you've got a minute to respond to this.
Oh.
So real quick, are you concerned about travelers to Brazil, especially, or other endemic areas for paracoxy? And by comparison, travelers, let's say, to Thailand or Laos as it relates to tularemycosis. Are you concerned about returning travelers with either of those endemic conditions?
Yeah, that's a good question. So if I had a highly immunocompromised patient that wants to travel, I think that Talaromyces is a lot lower risk unless they're in very rural areas. I mean, most of those cases are in real rural areas. There's some exceptions, of course. And then paracoxy, probably a little higher risk. And the problem with paracoxy is there's been presentations 20 years after exposure for paracoxy, which can be really problematic. So I would probably counsel them to, reconsider their travel plans in highly immunocompromised patients. But I think that on an individual basis, it's pretty unlikely that they're going to get infected.
Okay. Sharon, I have one question for you, and that has to do with changing of these, determining outcomes for these patients with moles. We've had lots of discussion about this, and I think we all can agree that success for a patient with mold infection is not defined as we might define success, say, for a crypto or a Candida patient. Do you think that's going to come about? Do you think we're going to see more reasonable endpoints or measures of success or stability? Maybe stability is success, that sort of thing.
Thanks, Pete. That's a difficult question to answer. And my quick answer is that with the MSG at the helm, I think we will. More reflective answer is that when we define responses, we look at clinical criteria, we look at radiological criteria, we look at mycological criteria, and perhaps the weighting of these criteria at different time points and with different mold infections needs to be refined a bit, because sometimes we can't justify doing CTs or MRIs at each time point to assess criteria when the patient's perfectly well, and then you have an outcome of stable disease, which equates to failure, which I think is perhaps might be unfair on the agent that we're looking at. So
Right.
I don't have an answer to your question, but I would agree that it's a need that needs to be addressed.
It must be addressed. Okay. Well, we've only got a few minutes, so I want to just make a couple of summary comments and then we'll adjourn. First of all, I'd like to thank those of you who attended today and have listened. We had a very good group. I think we got to all the questions. I want to thank, by the way, two of our respondents who provided us with references about the global warming fungal virulence or fungal emergence issue. So please look at that in the chat or in the Q&A, because that is really interesting stuff. But I want to thank the participants especially. The discussion from the WHO was outstanding. It gave us a really nice background in each of the kind of pathogen directed or pathogen specific discussions were just really outstanding and really state of the art. So really appreciate your participation in this. It's wonderful to have experts to whose brains we can pick, as it were. Really like to thank our colleagues from Terra Nova, Lisa Tushla, Tom Davis, for organizing this. They're invaluable partners to us, and we really appreciate them. And then finally, like to thank my partner in crime, Louis Ostrowski, for heading this up and doing such a wonderful job of getting us started today. So with that, I just want to thank everybody again and wish you a wonderful day. Sharon and Joe, those of you who are across the, and Anna too, I guess you're in Geneva, but thanks for staying up late or getting up early to join us. We really appreciate it. Okay.